Greetings, farm students. This is your week 2 focus video. Let me start out by saying chapter 1 in your ebook, which is Introduction to Drugs. You can skip over that if you like. It talks about the FAA and not the FAA, the FDA and the DEA and all this governmental, oversight of drugs. It's important, but it's good to know or nice to know. It's nice to know. Let's put it that way. It's nothing that you're going to be tested on. So let's get into, actually, chapter 2 and 3 kind of go together. That is drugs in the body and then the toxic effects of drugs. So in those chapters, I do want you to focus on terminology. There's some great animations about absorption, distribution, excretion. I'd like you also to pay attention to the concept of receptor sites on cells. A great example of why is this important to nursing. There's so many elderly people on, let's say, Coumadin. We use a laboratory test called an INR, International Normalized Ratio, and it's a reflection of what the pro time is, the prothrombin time or the bleeding time. Coumadin is an anticoagulant, which people will say it thins the blood, but it takes longer to form a clot if you're on Coumadin. And yet this is a very important baseline drug for many, many older people. Well, there's certain antibiotics that when a patient is on Coumadin, the antibiotics compete for the same receptor sites as Coumadin. So some of those antibiotics have like bigger boxing gloves, and they'll punch those Coumadin molecules right off of the cell and basically provide more free-floating or free availability of the Coumadin. And so when a patient comes in, their complaint will be that maybe they've got blood in their urine, and we run a ProTime and an INR. If you're on an anticoagulant like that, we expect your ProTime to be, or your INR to be above normal. Normal is 1.0. Mine is, yours is 1.0 because we're not taking anticoagulants. Theirs is between 2 and 3. We'll find patients that have INRs of 7, 8, and 9. And we're like, what, are they overdosing? Are they just sitting at home taking Coumadin? No, their doctor has prescribed an antibiotic that is increasing the availability of the Coumadin because that antibiotic is taking over the receptor sites on the cell. So that's why it's important. That's a great example of drug-drug interaction. And when we see these commercials that say, oh, this is a great drug, make sure you tell your doctor if you're on chemotherapy or blah, blah, blah. And you're like, why? Why wouldn't the doctor know that? I don't know the answer to that other than people do find their health care in various places like urgent care centers or whatever. So that's a great example. I want you to read about receptor sites on cells and who wins the battle when there's more than one medication looking to latch on to that receptor site. So like I said, that's a great example of drug-drug. There's also drug-food interactions, so I want you to read about drug-food interactions. And then there is a little bit of information here about some laboratory tests that we do run in conjunction with certain medication groups. So do read about what those are, and I've given you an example of one, which is the prothrombin time. I'd like you to read about the toxic effects of medications that can be found in the liver and the kidney. That's part of the excretion process. How does that manifest itself? How do we measure or how do we assess for toxic effects on the liver and kidneys? There's some laboratory results that we look at for that. And then also, how do some medications affect glucose metabolism? How do some medications affect our potassium, our serum potassium levels? And that pretty much takes us through chapters 2 and 3. If I didn't mention half-life, I do want you to know about half-life as well. That should be in drug metabolism. It's in chapter 2. Sorry, I overlooked that. a great example of why do nurses need to know about half-life. I had an occasion where a student gave a medication, a student was working with a nurse, gave a medication. The medication was glipizide, which is oral anti-diabetic medication, and it works to reduce the amount of circulating glucose, keep the blood glucose down. This patient was not diabetic. She gave the medication to the wrong patient. The nurse had given her the medication, gave her the computer with a different patient's profile pulled up on the computer. So she was giving her the medication glipizide. Here's some glipizide. I want you to give it to this patient. The glipizide was on the computer, and then when she went into the patient's room, she said, this is before scanning, she said, can you tell me your name and birth date? So she's doing the right patient check. And she looked at the patient's armband, and the patient indeed said the same name and birth date that was on the armband, so that matched, but it didn't match back to the computer. There was that was patient B up on the computer. She's talking to patient A. Anyway, long story short, she gives this medication. We quickly determine that there's been an error, have to notify the physician, have to tell the patient, have to tell the family. But the first thing I wanted to know is, what is the half-life of glipizide? Because I want to know, how long do I need to be vigilant about the side effects of glipizide on a patient that does not need it? There was nothing we could do to offset the effects other than, giving the patient extra carbohydrates, and then not continuous, but frequent monitoring of the patient's blood sugar by finger stick. So we called the pharmacy. We looked it up, but we also called the pharmacy to get that information from a clinical pharmacologist who told us what the half-life was. And then I want you to know what the half-life is, what the concept is, because it's more than just the half-life. When, if I give 2 milligrams of something, when does it become 1 milligram as far as circulating? And then what happens after that? So I want you to know it plays out, it plays out, it plays out. So there's a great example in your book of how you actually calculate the half-life of a medication. And that's why that's important. Okay, then that's chapters 2 and 3. Then chapter 4 is nursing process and drug therapy for patient safety. Paramedics, this is a big one for you because this is going to be new. This is the nursing process. Introduction to the nursing process, assessment, nursing diagnosis, intervention, evaluation. And the nursing assessments, the nursing considerations that we need to employ every time we give. It's going to change the way you look at medication administration, I swear to you. Even some of you LPNs, when you look at all that's involved in this chapter. So I've been referring, I think, earlier to the 6 rights. I might have said 6 or 7 rights, depending on the text. This text actually teaches 7 rights. So the rights that I know are right drug, right route, right dose, right time, right documentation, right preparation, and then this book adds right storage. So has the medication been stored properly? Probably by the end of, well, where are we? We're 2018. I was going to say by 2020 we'll have 10 rights of medication administration. They'll find other things to include. But this is the chapter that lays out the importance of no shortcuts, which I mentioned in the intro video. So somewhere along the line here, if you were to omit or sidestep any of these 7 rights, you could be actually making a medication error. And over all my years in clinical with students, there has never been a mistake made when students are giving meds with me. I can tell you that. I'm very proud of that. The mistakes that students have made is when they're giving meds with their nurses, and their nurses are not paying close enough attention to them. And in this case that I just described, that was kind of a nurse-facilitated error, although the student could have prevented that error. If the student had taken the name from the patient and looked at the computer, at the name across the top of the computer, and said, you just said your name was Joe Smith, this says Bill Baker, There's something wrong here. This will also be an introduction for you on nursing diagnosis and LPNs. This may be an introduction for you all on nursing diagnosis as well, which is a hard pill to swallow, no pun intended. But nursing diagnosis is something that we have to learn about and master as we go through the nursing program. The other feature that is emphasized in this chapter is the importance of patient teaching. What are the nurse's responsibilities to teach the patient about this medication, about all these other considerations that we've talked about previously, food-drug interaction, drug-drug interaction, etc. It does talk about medication errors in this chapter as well. And at the very end of the course, I'm going to show you a video called Just Culture. And I don't know if you've heard of this concept. It's been around for a while. It's a concept that was borrowed from aviation, but it's about the idea that we do not cover up mistakes. In healthcare in general, we are not supposed to cover up mistakes. That's not part of our ethical framework. When it comes to medication errors, we do not cover up these errors. We report them. And because I've taught paramedics for so many years, I know that does not always, that's not a guideline that always crosses over to the field. I know there's, the brotherhood and, hey, I'll watch your back if you watch mine. That does not fly in the hospital. When a medication error is made, it is reported. But gone are the days when you're out the door, you lose your job. If the facility has adopted some of these just culture principles, and I know that at least at Banner, where I had most of my clinical time, they were implementing this as recently as 4 years ago, where everybody comes together and it goes to risk management, and they talk about the environment that the mistake was made and what facilitated that mistake and how could we keep that mistake from ever happening again. Be very surprised to hear or learn how often it is related to the organization and not necessarily to the practitioner themselves, or that the organization has some sort of process in place that facilitates such an error to be made. Okay, then we go on to Chapter 5, Drug Calculations or Dosage Calculations. I don't have too much to say about this chapter other than you can overlook all the pediatric adaptations for calculations, because I'm not going to hold you to any of that, but telling you that you won't be able to get out of the nursing program unless you know how to do drug calculations. If you are a person who has a particular deficiency in some of that basic math calculation and conversions, email me. There's a Canvas course that's put on by Gateway, and it's free of charge, and it's like a workshop or whatever. But I've had some students that have taken it, and it's really helped them a lot. There's also a text that we sometimes recommend for students who struggle with that called Calculating with Confidence. Calculating with Confidence, and it's a workbook, but it teaches you step by step how to do these conversions. I know when the paramedics come in the first day of class, I give an assessment test of just like 10 math questions. Probably 70% of them are struggling with one thing or another. And it has to do with how often you use this skill. It is not trust me, I am not a math genius. I have my calculator out whenever I need to have it out. It has to do with how often do you use that part of your brain to do those kind of calculations. And we do have some medications that are considered high-risk medications that you're never really supposed to give based on your own calculation. You're supposed to have 2 people do that calculation before you give it. It's not a sign of intelligence. It's a sign of a part of your brain that hasn't been utilized. That's what I think. But anyway, give me an email if you need some more resources related to calculation. Chapter 6 is about the challenges to effective drug therapy. And here too, this has to do with the lifespan and some elderly people. When you go into a hospital, what is the average age of the patients that you're seeing? I really don't know the average age, but I want to say in the late 60s, 70s, maybe something like that. The whole concept of polypharmacy, which is taking many, many drugs, and the more drugs a patient takes on a daily basis, like do they take 2 pills? Do they take 3, 4, 5? Do they take 7? There's an exponential increase in the likelihood of error. And also another concept, like I would say within the last decade, is alternative therapies and alternative herbs, for instance, or supplements. I can remember back in the day doing intake for patients coming into the cath lab, and what are the medications that you take? And I'm writing down their medications, and they start to say, and I also take glucosamine, and I'm like, yeah, I don't. Okay, what about the real medications? All these over-the-counter medications and alternative therapies, they actually do. Once I started teaching pharmacology, I'm like, holy crap. These herbals and supplements and generic things like St. John's wort, for instance, and ginseng, they do interact with prescribed medications. So in and of themselves, they cause no harm. But combined with certain medications, they can actually either negate the effectiveness of the prescribed medication, or they can turn it into a super therapeutic dose, like an overdose, basically. So it runs the whole gamut as far as interactions, but that definitely is a challenge to effective drug therapy, and it means that we have to be skillful in our questioning as providers. Not asking simply about your prescribed medications, but any other medications and over-the-counter. And then you have to deal with the whole over-the-counter concept that if I can buy it without a prescription, it has to be safe. I can buy Advil or Motrin or whatever at Costco in a big, huge jug, and it costs me $5. But that doesn't mean it's safe to use. If you read the fine print, it'll say as prescribed. If you must use this drug for more than 5 days, consult your physician. I know of somebody who actually required a kidney transplant because of, it was called NSAID abuse, nonsteroidal anti-inflammatory, ibuprofen, that she took daily, multiple times a day for certain kinds of aches and pains. And it was very helpful and effective for that. Unbeknownst to her doctor, unbeknownst to her, she was basically putting herself into renal failure, which is what finally happened. So over-the-counter drugs, over-the-counter does not equal safe. It just means that you probably require even more supervision because you don't have a physician instructing you on how to use it. It relies, safe administration relies on you reading the labels, and who can even read them because they write them in a font of 2. So over-the-counter medications is a huge consideration. And then I mentioned the alternative therapies and those people who treat themselves. Polypharmacy I mentioned, pill splitting, and the whole idea of the physiological considerations that affect the pharmacokinetics of the drugs that our patients take and that we give. Okay, now moving into GI meds. So this is going to be more like what your focus videos are going to be like every week, what we're going to get into right now. And basically, we're going to cover the drugs that act on the gastrointestinal system. Every time we cover a classification of drugs that affects a system in the body, there's always going to be a chapter, like this one has, Introduction to the Gastrointestinal System, which is chapter 56. I'm telling you that if you've taken anatomy and physiology in the last, whatever, if you've still got something going on in your brain related to the GI system, you may be able to breeze over that chapter on Introduction to the System. I'm not going to tell you about anything that you need to focus on in that chapter. So then what we're left with is 57, 58, and 59, drugs that affect gastrointestinal secretions, drugs that affect motility, GI motility, and then antiemetic or nausea medications. When it comes to secretions, basically we're talking about acid, stomach acid. So in Chapter 57, actually that's the chapter that I'll be showing you. As soon as we're done with this, we're going to have a quick review of how to smart read chapters. I do want you to look at classifications of medications. What is stomach acid exactly, and how do antacids work? Where do they work? In the stomach. And how do they work? Also, H2 receptor antagonists or H2 blockers, how do they work? How do PPIs work? Proton pump inhibitors. What are the drugs that are in that class, PPIs? And then some of the medications that I want you to focus on, famotidine, which is Pepcid, and we do give pantoprazole, which is Protonix. That's a proton pump inhibitor. When it comes to trade name versus generic name, the consensus today is that you really need to know both. The best example of why you need to know both is that in your computer, for instance, in the Banner system, they only use the generic names. But if you don't know that, for instance, furosemide is Lasix, you could be having a conversation with your patient that is totally off the wall. Or you could be looking at a prescription that the patient's, the discharging doctor has written, a prescription for Lasix, and you don't realize that the patient's already on Lasix at home because you don't know that furosemide and Lasix are the same drug. You as the discharging nurse would be the last safeguard to correct that error. And that's why nurses need to know both. The other drugs I want you to know off that list are sucralfate, and misoprostol. Those are drugs that work in other parts along the GI lining and in the intestine. So compare the pharmacokinetics of these drugs. So I want you to learn the drugs so that you can have a discussion about it. You know what class it is and you know why we give it. Would you say that Pepcid and Protonix are interchangeable? Which of those two drugs would be the most effective to reduce gas? So what precautions does a nurse need to take to when administering one of these drugs, and what patient teaching is required? So again, you'll see as soon as I'm done talking here, I'm going to show you these boxes that are highlighted in your reading that talks about just that very concept, nursing considerations, patient teaching for these drugs. Then in the next chapter, I call it bowel disorder medications, but it is like antidiarrheal medications or laxatives, the two ends of the spectrum. Antidiarrheals and laxatives. Probiotics, which are considered intestinal flora modifiers. Probiotics are huge now, and because I'm older and I always think something just happened yesterday, and maybe it's been about 10 years. Well, this takes us back to Protonix. So if you look at evidence-based nursing and medical care, back in the day, one of the most common complications of a hospitalized patient was the development of a gastric ulcer. Back in the day, patients stayed in the hospital a lot longer than they do today. Patients stayed in the hospital for 5 days, 7 days, 9 days. They'd be NPO for days on end because there's diagnostic tests coming up or whatever, and we're giving you new medications that you're not familiar with. And there's the stress, the physiological stress of whatever the disorder is that you have, along with the psychological stress of you being in the hospital, you have no control over what's happening. So wrap all that together, and the end result for many patients was the development of an ulcer. And in some cases, those manifested as bleeding ulcers, and in some cases, there were actually fatalities as a result of these pretty much hospital-induced bleeding disorders that developed over time. So our answer to that was to prescribe proton pump inhibitors to decrease the amount of acid that's being produced in the stomach. So it sounds logical. It sounds like we're very patient-oriented, and we can't understand why that wouldn't benefit the patient. And I'm sure it has benefited millions of patients. It became the standard of care that we give Protonix or another version, Pepcid. Protonix and Pepcid, actually I'm answering the question. In some cases they are interchangeable. The doctors get together and they say, we prefer Pepcid because blah, 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 which is fine. The idea is the same, that we're going to decrease the stomach acid to help protect the patient against the stresses of their disorder or being hospitalized or a combination of all of the above. Put that in a box over here for a second. Then let's go back to our basic pathophysiology, which is what is the role of the GI tract in our immune system? And if you go back to basics, maybe in physiology you covered this. The mucosal lining is one of our, aside from our skin, our mucosal lining is probably the number 2 feature of our immune system. By administering Protonix, which decreases the secretion of acid, the acid actually plays a part in our immune system, but now we're decreasing that. For some patients, that actually opened up an opportunity for some kinds of infection. If you do a literature search, there are people who have seen a relationship between the administration of proton pump inhibitors and the development of C. diff, Clostridium difficile, which is the dreaded in-hospital infection that occurs usually in people who are on antibiotic therapy. So when we talk about drug-drug reaction, there is always considerations to be made, even though our hospital policy says that all the patients should be given Protonix daily. Well, I say, let's look at each patient individually. Let's look at them individually and see if it's more likely that they'll benefit from this medication or more likely that they may not benefit from the medication. Let's not be so rigid. Let's not be robot nurses. That's what I am a big fan of. Don't be a robot nurse. Be a critical thinking nurse who looks at each patient individually and looks at what their needs are. But that's a little interesting background on, how did I get into that? Oh, probiotics. Probiotics, because now we give probiotics very commonly when we start patients on antibiotics. So we're going to give you an antibiotic in this hand, we're going to give you a probiotic in this hand, because that's going to help to maintain the integrity of the good flora in your GI tract that could otherwise be knocked out by the antibiotic and set you up to be a host for C. diff. So that's one reason now we see probiotics in the hospital, very commonly, lactobacillus, if a patient is on antibiotics. And we also have medications for irritable bowel. There's something called bowel care of choice, which is a doctor saying, you nurse can determine with the patient, what does the patient take at home for constipation? What does the patient take at home for diarrhea? We're more willing to treat constipation in the hospital than we are to treat diarrhea, because sometimes the idea is that if the patient's experiencing diarrhea, they need to get that out. And we shouldn't be giving them drugs to prolong whatever that irritation is. We need to allow that to run its course. So drugs I want you to look at are Lomotil, Imodium, Colace or Ducasate, which is the stool softener. That's commonly given. In one hand, we're going to give you a narcotic pain reliever. In this hand, we're going to give you a stool softener, probably once daily, because narcotics slow down the GI tract. Narcotics will constipate the patient sooner or later. So why not give them a stool softener in concert with that? Look at the medication Lactulose, and we talked about the probiotics Lactobacillus. A nursing consideration for any patient who is on these kinds of medications is going to be fluid and electrolyte imbalance, because It is your large intestine that is mainly responsible for preserving or withholding, pulling back water into the circulation. So fluid and electrolyte imbalance is an important consideration. And then our last chapter is on antiemetic drugs. So there's 3 or 4. I think there's actually a question in one of the chapters about compazine. I don't see compazine being used very often, but it is in that class and it is going to be on the list, and so you should be able to answer the question about compazine. Ondansetron sounds like one of Santa's elves. Ondansetron is Zofran, and that is probably the most popular antiemetic that we give in the hospital, Zofran. But I also want you to look at Reglan, R-E-G-L-A-N, Reglan, and promethazine. So add compazine to that list as well. It is a very common admission diagnosis for a patient to be admitted to the hospital with abdominal distress or nausea, vomiting, diarrhea. Very common. Or just the nausea and vomiting. Nausea is the most common post-operative complaint of patients, and it is a reaction to anesthesia, and it usually lasts for 24 hours, but we like to medicate the patient because the last thing we want a post-op patient to be doing, let's say they've had something, an abdominal something going on, the last thing we want them to be doing is retching and vomiting and, causing extra stress on their abdominal cavity. Okay, so there we're, whoops, I got a sneezing dog. There we are. Also need to remind you that the exams are timed because they're not meant to be open book. If you start to look up the answers for a question, likely you're going to run out of time and you'll end up shooting yourself in the foot in that way. Do the reading, prepare, and then do your best. Give it your best shot at that 10-point quiz. Do I have every reason to think that you're going to be successful? Hey, you're LPNs and paramedics. You know how to do this.